I hope everyone can hear me. My name is Dr. David Kraus. I'm the Chief Medical Officer at Genomind. Welcome to our Grand Rounds meeting. This is the first of what will be an ongoing series with our customers, clients, and outsiders. And we intend to form an educational institute specifically directed at pharmacogenetics as an added benefit for our users. Today, I'm very pleased to introduce Dr. Chad Bousman. Dr. Bousman is an associate professor in the Department of Medical Genetics, Psychiatry, Physiology, and Pharmacology at the University of Calgary. And Chad and I have known each other a little bit over the last several years during my involvement at Genomind. What prompted my invitation to Chad to speak today was an article, actually a letter to the editor, which he co-authored in the Journal of Child and Adolescent Psychiatry. And that letter was a response to a position paper that was written by the Academy with respect to pharmacogenetics. And I think it's fair to summarize it by saying that they did not find utility in it for children and adolescents. And Dr. Bousman and his colleagues wrote a very thoughtful rebuttal to that article, in which he talked about the evidence for pharmacogenetics, including FDA labels, CPIC guidance, randomized clinical trials, and so forth. And these are the exact same sources of the evidence that we use in our assay. So having said that, I'd like to welcome Dr. Bousman. We will have about 45 minutes of presentation. Then we'll have a Q&A, which will be by chat, not verbally. I think everyone should be muted. Dr. Bousman, welcome and thank you.
Okay. Well, thank you for that introduction. Okay. All right. So thank you for the introduction and thank you for inviting me to speak on this topic, pharmacogenomic-informed prescribing in mental health care. So I'm going to provide a quick overview at the beginning of my talk of the rationale and evidence for using pharmacogenomics in genetics and mental health care. And then the second part of my talk, I'll discuss some of the current considerations and complexities of implementing pharmacogenetic testing in the mental health care setting. And I'll finish off with just a very brief look forward to the future of pharmacogenetic testing. Now, I will say that I'm going to cover some topics maybe in a bit too elementary level for some, but I want to make sure everybody's on the same page. Those of you that are fellow experts or know this stuff, bear with me as we go through that. I think it's important that everyone is on the same page. Okay, so starting with the rationale, we know medications do not always work. I don't think that's controversial. At the best of times, 38% of individuals don't respond, and at the worst, we have 75% not responding. We also know that medications can be dangerous. And so this leads us to a current state where medication efficacy and tolerability varies from person to person. So this provides an opportunity that we need personalized prescribing strategies. Now, I like to state up front in all my talks on pharmacogenetics that there's many personalized prescribing strategies. Pharmacogenetics is really the new kid on the block when we think about all of the other strategies that have been ongoing for decades and that are being used in the clinic today, some of which I've listed here. And what I want to make sure is clear now and throughout my talk is that pharmacogenomics really is meant to serve as a companion for these other personalized strategies. It's not meant to stand alone or replace any of these other strategies. Okay, so pharmacogenomics, we use genetic variation as a surrogate marker of a person's ability to process and react to drugs. And as a pharmacogeneticist, I typically lump this genetic variation into two broad categories. We have genetic variation that is involved in genes related to pharmacodynamics, and then we have genetic variation in genes related to pharmacokinetics. Now, in the field of pharmacogenetics, we tend to focus on metabolism, and that's where the majority of the evidence base is to date. And so today I'll be focusing on metabolism, but I will state that there is a large body of evidence that is evolving that's looking at genetic variation in genes related to pharmacodynamics, as well as other components of pharmacokinetics. So as many of you probably are well aware, the cytochrome P450 system is responsible for the metabolism of the majority of drugs that are available. Today, I'll be focusing on two primary enzymes in that system that are related to mental health, or the big players in mental health prescribing. That's CYP2C19 and 2D6. So collectively, these genes metabolize the majority, if not almost all, of the antidepressants that are out there. About half of antipsychotics, a few anxiolytics, and ADHD medication, atomoxetine, as well as other ADHD medications, but atomoxetine in particular. So what I want to kind of provide a little bit of an overview of genetic variation in CYP2D6 and C19, because this will set the groundwork for further slides in my talk. And some of you are probably very familiar with star alleles. Other of you have seen them, but you really don't understand why we have to have star alleles, whereas other areas of genetics, they don't use star alleles. Well, the star alleles were developed to be easier genetic nomenclature for the non-genomic specialist. And so each star allele really represents a haplotype, or a group of variants that get inherited together. Some of these haplotypes lead to an amino acid change, or others may affect transcription, splicing, translation. They basically have some type of function on the gene and the encoded enzyme, in this case, CYP2D6 or C19. The other important thing that I want to note is the star 1 is a reference or a default allele. So no assay actually includes any variant that tells you it's star 1. You get a star 1 after running your assay, and you don't detect any of the variants that you were meaning to detect. So it's kind of a default setting. So if an assay was only measuring 3 variants and you didn't see those variants in that particular individual, they get assigned the star 1. So this is just to set it up that the more variants you look for, the less likely you are to get that star 1. The fewer variants you look for, the chances are a bit higher that a star 1 would be assigned. So how do we get to these star alleles? So like I said, they're haplotypes. And so if we look here, these are an example of CYP2D6 and C19 from the Pharmacogene Variation Consortium. And anyone can look at this. This is called a CAVE tool. Basically, you can select which star alleles you want to look at, and it'll tell you what they comprise. So if we just take a look at the bottom 2 variants there for CYP2D6, we can see that both star 2 and star 17 both include these variants. But if we wanted to differentiate a star 2 from a star 17, you need that third variant here that will tell you that this individual is a star 17 if that variant is present. If it's absent, they would be a star 2. So that's just a quick example of how we determine the star alleles. And the same thing can be done for CYP2C19. So once we have the star allele and the haplotype, so the next step is to provide an activity score for that haplotype. So what is the activity score? Well, each star allele is lumped into these one of these 4 categories. Either it has a no activity, reduced activity, normal, or increased. And a score is associated with each of those. So for the no activity, you get a 0. For reduced activity, typically it's a 0.5, sometimes 0.25. Normal is a 1, and increased is 2 or more, depending on how many copies of that allele an individual carries. And so if we know what a person's diplotype is, which is basically the 2 haplotypes, or we sometimes just call it genotype. So in this case, we have a star 1, star 4 individual. And so if we add, we could do a simple math, and the star 1 is a score of a 1, and the star 4 is a no activity, so 0. So they have a total activity score of 1. So once we have an activity score, then we can assign the phenotype. or the metabolizer phenotype. And you can see here, if that individual was a 1, they would fit right here in between the 0.25 and 1.25. And so they would be considered an intermediate metabolizer. In fact, you can see here, it's shown in the cartoon, you have 1 normal allele or star allele, and then you have 1 no activity allele. And just note here that the percentages above each of these phenotypes is just the approximate proportion of the population that would be assigned those phenotypes. And the reason why they're so wide range is because it's across different ethnicities. And the same thing can be said for CYP2C19. I'm not going to go through this in detail, but I just want to note that for CYP2C19, depending on which nomenclature you're using, some will include this rapid. I include the rapid because that's what the Clinical Pharmacogenomic Implementation Consortium, or CPIC, does. But if you're following the Dutch guidelines or other guidelines, they often will collapse rapid and normal together. So that's just something to keep in mind. So now once we have someone's phenotype or predicted phenotype, the next step is obviously to figure out, well, what does that mean clinically? And so we need to look at the evidence base and say, well, what is this phenotype associated with? Which drug gene pairs are actionable? And so this starts with looking obviously at the published literature, but also the drug labels. And fortunately, we don't have to do that anymore by hand. We can do it, but we're fortunate to have the pharmacogenomics knowledge base, or PharmGKB, who does a lot of this curation of the gene drug pairs. So they extract gene drug pairs from the evidence bases, they curate it, and then they grade it on this strength of evidence scale. And there's 4 levels of this scale. There's the preliminary, which is just the case report or preclinical evidence, often just animal models. There's a low level of evidence in which the gene drug pair has been associated, but there's not any replication, or there's a lot of studies, but there's conflicting findings. There's the moderate, which is a multiple replications with small effect. So some would argue that it's probably not clinically relevant. And then we have the high level of evidence, which is multiple replications with a large effect that has clinical implications. If we just look at the breakdown of what's in the pharmacogenomic knowledge base, we see there's about 450 gene drug pairs that are relevant to mental health. You see the majority of these are in the moderate level, strength of evidence. But what we're really interested in is this group, this small but important group, 5%, that have that high level of evidence. And it's this group that moves on to guideline development. Now I'm putting here up the 4 main guideline developers, and really it's the top 2 I would say are the main drivers of pharmacogenomic guided guidelines. I mentioned CPIC already. It's based in the US. It does have an international membership. And then there's the Dutch guidelines as well. And I'd say between those 2, the majority of the guidelines have been developed. All up, we have 106 gene drug pairs with pharmacogenetic-based guidelines that comprise 23 genes and 81 drugs. This is quite a busy figure, I know, but it depicts all of these 106 gene drug pairs. And I like it because it really shows that pharmacogenomics crosses a number of the specialties in medicine. But today, obviously, we're going to be talking about mental health. So if I just zoom in on the mental health component, and here I've also added in the drug label data as well. So not just the guidelines, but also guidelines that are associated with the drug labels. And that brings us up to 42 gene drug pairs with actionable pharmacogenetic-based guidelines. As you can see here, that comprise 7 genes, 34 drugs. And you can appreciate right off the bat that CYP2D6 and C19 make up the majority of those gene drug pairs, along with, on the drug side, the antidepressants and antipsychotics. So based on that evidence that we have to date, and there was a lot of, the International Society of Psychiatric Genetics wanted to do a review and consensus on pharmacogenetic testing in psychiatry. So despite all that evidence I just showed you, there was still in the field a bit of indifference about pharmacogenetics. So we put together this, this panel of experts and created this consensus process. And our overarching kind of, I guess, theme or overarching message is that pharmacogenetic testing is a tool to enhance rather than offer an alternative to standard treatment protocols or other personalized prescribing strategies. And this is something I mentioned at the top of the presentation, just echoing that here. But our consensus was that the current evidence supports pharmacogenetic testing for specific antidepressants, antipsychotics, mood stabilizers, and ADHD medications. On the other hand, the current evidence does not support testing for anxiolytics, addiction medications, nor does it support genetic variants in pharmacodynamic genes, at least in psychiatry. Okay, so I wanted just to provide a case example of how pharmacogenetics can be helpful at the clinical level in the adult setting first off. So this is a 67-year-old male, major depressive, primary diagnosis of major depressive disorder. He was admitted to hospital with suicidal ideation and catatonic symptoms. And prior to his admission, he had been given trials of citalopram and escitalopram, both at maximum dose, but showed minimum response. The decision was then made to start ECT. His mental state did improve following ECT, and then he was prescribed sertraline prior to discharge. But shortly after discharge, his depressive symptoms reoccurred and he was readmitted. And so this is when the attending psychiatrist ordered pharmacogenetic testing. And so here I'm showing the results of that test. And you can see he was a rapid metabolizer for CYP2C19 and a CYP2D6 normal metabolizer. So let's kind of just unpack this a bit and look at the evidence and guidelines. So first off, if we look at the CYP2C19 substrates, you can see, I've asterisked here, the 3 drugs that this patient was trialed on are all CYP2C19 substrates. The drug labels for citalopram and escitalopram both mention CYP2C19. And the dosing guidelines, both the Dutch and the CPIC guidelines, both suggest that for all 3 of these drugs, an individual that is a rapid metabolizer, we should consider alternative drug not predominantly metabolized by CYP2C19. And then finally, the Pharm-GKB lists these gene drug pairs in the high strength of evidence, so multiple replications and a large effect. So in the end, what happened was they discontinued sertraline based on that pharmacogenomic report, and then they started paroxetine, which is primarily metabolized by CYP2D6, and patient was then discharged 3 weeks later and remains well in the community with no further relapses. So the take-home message here is that pharmacogenetic testing could significantly reduce these types of experiences, expedite time response. So in this case, you know, he had 3 trials of antidepressants before finding the right one, and could avoid unnecessary treatments. In this case, it's possible that ECT was not needed. In fact, it probably wasn't. It was an unnecessary treatment that this individual had to go through. Okay, so as David said at the beginning, I want to talk a little bit about the pediatric implications. And so what does pharmacogenetics have for the pediatric mental health setting? Well, we recently did a review of the antidepressant literature, and this was a systematic review of 24 studies that included 1,600 children. And what we found was pretty much that the pediatric results to date echo what we see in the adult populations, with few exceptions. You can, and this little figure here kind of just shows the different relationships that we found. These are only significant relationships that are depicted. And what I'll focus on is the CYP2C19 escitalopram and citalopram gene-drug pairs. And I'm focusing on that is because one of the largest studies that was included in the review included 250 youth treated with escitalopram or citalopram. And as you can see here, I think it's pretty easy to appreciate that children with the actionable CYP2C9 profiles, so the two ends, you get the poor metabolizers and ultra rapid, were more likely to discontinue therapy. So what we see is this U-shaped curve, which is commonly seen in pharmacogenomics, in which we have the two tails of the distribution showing the largest effects. Now, we also looked at antipsychotics, and this is a review that just accepted a few weeks ago, so it should be online soon. Looking at a systematic review of 20 studies, just under 1,100 children and youth. And here the results are still a bit more tentative, but we found that CYP2D6 genetic variation does seem to have an impact on risperidone pharmacokinetics, as well as adverse drug reactions. There wasn't much evidence to suggest any effect on efficacy, but given the number of studies and the number of children and youth studied, that needs to be taken with a little bit of preliminary lens. But for risperidone, what we see is that CYP2D6 poor metabolizers certainly had an increased propensity for adverse drug reactions, and that had a lot to do with the altered pharmacokinetics of risperidone in those individuals. Now, after we finished our systematic review, I'll note that there was a new study that just published of 277 individuals, youth, that suggests a similar finding for CYP2D6 and aripiprazole. And that kind of that aligns with the FDA drug label that has CYP2D6 based dosing for aripiprazole. Now, an important caveat to keep in mind when implementing pharmacogenomics in pediatric setting is that developmental factors can affect all levels of drug pharmacokinetics and dynamics. Here in this picture, I'm just showing how the effect on enzyme activity over development, and particularly highlighting CYP2C19 and 2D6. You can see here, CYP2D6 reaches adult levels soon after birth. So the enzyme activity is at adult levels well before probably any antidepressant would be prescribed in the majority of the cases. But something to keep in mind is that although the enzyme activity is at adult level, hepatic capacity is still lower than an adult, given the size of the liver is obviously not in its full capacity. For CYP2C19, you can see here quite easily that CYP2C19 is much higher enzyme activity in early childhood, and then it slowly dips back down to adult levels in adolescence. So this is something that needs to be kept in mind when seeing someone's genetic profile, predicted phenotype, versus what they might actually phenotypically be in the clinic showing. Despite that caveat, I will note that there are places that have been implementing CYP2C19 and 2D6 testing into routine care for quite a long time. And I'm highlighting here Cincinnati Children's. There's others, but I would say that they're a great example. They've been implementing it since 2004. They've implemented over 25,000 pharmacogenetic tests, and this has been routine care for inpatient psychiatry at the hospital there. Okay, so that was just kind of an overview of kind of the rationale and evidence that exists to date in pharmacogenomics, both in the adult and pediatric realm. Now, the second part of the talk, really what I want to get into is the implementation considerations and some of the complexities with implementation. And as you can see on this figure, there's a number of items that I really want to kind of get into in a bit of detail and go through step by step. So the first is the selecting and ordering. And we know that there are many test options that are available. In the US alone, there's more than 75 tests or 75 labs that offer pharmacogenetic testing. And if we look worldwide, it's probably well above 150. So that always leads to the question, and it's probably the number one question I get asked, is which test or what test should I use? Now, based on getting that question repeatedly, myself and colleagues put together this guide to test selection. And this was published last year. I don't expect you to be able to see this and go through this, but it's just to highlight if you want more information to go there. But I'll give you the gist of it. It's basically, we want to look for a test that is as evidence-based as possible, is done in an accredited laboratory, is transparent about what they're testing and how they get to their recommendations, and is supportive. So, in supportive meaning that they provide some kind of clinical decision support. So they're not just giving you the genotype and the phenotype and saying, there you go. Providing some type of consultation, either be paper or via telephone or in person. But one thing I want to make sure it's clear is that the current evidence does not suggest that any one test is superior to all others. But I will state that there are inferior tests out there. The second thing that I want to talk about in this section is, and a question I get asked also, not as much as what test to use, but when is the best time to order a test? And this is a tricky question to answer because it really depends on your setting, as well as a number of other factors, reimbursement being one of the big factors. So the most common strategy is a reactive one, in which initial drug selection and dosing is done using standard protocols, and pharmacogenetic testing is only ordered once a poor response or some side effects occur. The second strategy is the point of care, in which, again, you're using standard practices to dose or select the drug, but at the same time, a genetic test is being ordered. And the thought being that most tests can get results back to you in 1 to 2 weeks. So that allows time for adjustments to be made, particularly if we're talking about antidepressants that typically take up to 4 or 5 weeks to really work. And then finally, what a lot of us in the field are pushing towards is the preemptive testing. And this obviously is ideal. There's obviously reimbursement challenges for this, but the fact that if we had pharmacogenetic testing results available to us prior to doing any drug selection or dosing, that this would be ideal. We could base that on the pharmacogenomic profile and take a little bit more of the trial and error out of the process. Okay, so now I want to move on to content validity. So it's important to note that currently there's no regulatory standards for test content. So when I mean test content, I mean the genes that are tested, the variants that are tested. Currently, there's no standards for that. And if we go back to that figure that I presented earlier, we really need to, I guess, use that as our guide while we wait for some type of regulatory standard. These are, again, the gene drug pairs that have some guidelines, either on a drug label or from a guideline developing body. And so we'd expect to see these gene drug pairs on tests, or at least a portion of these, and hopefully not too many that are outside of this, outside of these gene drug pairs. And a couple of years ago, we decided to develop a minimum test panel for psychiatry. Is more of a suggestion just to get the field thinking about it, and to maybe push regulators to do something a bit more formal. And so what we did is, we selected the genes that are pretty much shown here on the right, with the exception of the PLLG and OTC because of their rare use and only linked to valproic acid. And then looked at what alleles really need to be included on a panel. And this, again, is the minimum. I wouldn't say this is the ideal, but the minimum. So when looking at a panel, if they did not include some of these alleles, you might want to reconsider is basically how we put this. And I will note that the Association for Molecular Pathology and the College of American Pathologists have proposed their own recommendations, and they pretty much align with ours, with the caveat that they have not published CYP2D6 panel guidelines yet, but I do know those are underway. We then want to look at whether or not, if we're proposing this minimal panel, we should at least look to see, well, how do some of the commercial tests that are out there and their mental health panels, how do they map onto this? And can these commercial panels facilitate use of the guidelines? And you can see here, if we look at all of the 5 gene drug pairs, only 14% cover all of the minimum panel. But that's a little bit misleading because, as you can see, the HLA and HLA-B is the main culprit for that. And a lot of commercial panels don't include HLA, HLA-Bs because, well, there's many reasons. One is that there's some complexities of genotyping those loci, but also that many jurisdictions have HLA A and B already offered, and it's standard practice. It's an institutionalized testing. So we really want to just look at CYP2C19 and 2D6 that are the main workhorse in mental health at the moment. And if you do that, you can see that the majority of the tests are able to facilitate the use of the guidelines. But I do want to note that outside of those 5 genes, there is usually on every panel I've ever seen some cautionary content, as I would call it. And what do I mean by cautionary content? Well, these are genes that have good face validity, gene drug pairs, I should say, that have good face validity. They have good biological plausibility, but at the moment, the clinical validity is inconclusive. So just as an example, here are 4 cautionary gene drug pairs. You can see that all 4 definitely have good face validity and good biological plausibility. Serotonin transporter SSRIs, the dopamine receptor D2 antipsychotics, COMT and methylphenidate, and CYP1A2 and clozapine, which is the main enzyme that metabolizes clozapine. But the fact of the matter is that the evidence to date doesn't support the use of this to guide clinical practice at the moment. And so to give you a little bit of just an idea of the commercial panels that we've looked at and the proportion of them that carry or include these cautionary gene drug pairs, you can see that it's a fair amount of panels that do have this content. So that's something that we need to keep in consideration when interpreting results from commercial testing. And all testing, I shouldn't say it's just commercial, even non-commercial tests sometimes include some of these. And just to give you an example of what can occur in this context of cautionary content, there's this case of a 25-year-old male, primary diagnosis of schizophrenia. And this patient was admitted to hospital on an involuntary basis due to bizarre behavior and command hallucinations. And he had a history of multiple medication failures. And so the treatment team decided, well, clozapine is the next best step. But the patient's family and the outpatient provider opposed this decision based on some pharmacogenetic testing results that they had ordered prior to this hospital admission. And that was ordered by the patient's outpatient provider. So I'm listing here the results of that test. You can see it's pretty much not much to be said about the results. Normal metabolizer across the board, negative for HLA-B, which really isn't relevant for this particular case. But what stuck out is that there's this DRD2 variant, and the predicted phenotype is a poor responder, particularly for clozapine, amongst a couple other antipsychotics. And so this is what caused the red flag to come up for the patient's family and the outpatient provider. So if we looked at in more detail about the evidence for this gene drug pair, what we can see is the drug labels make no mention of DRD2 for clozapine drug labels. There are no dosing guidelines for DRD2. And if we look at the Pharmacogenetics-GKB, we see the strength of evidence is currently low. So it's not that it hasn't been replicated, it's more conflicting findings. So there's a lot of research out there looking at DRD2 and clozapine response, and it's very mixed, which is why it has the low strength of evidence. So in the end, clozapine was commenced for this patient after the approval of the medical director and the patient consented, and the patient responded rapidly and was discharged. And he gradually returned to his previous level of functioning. So really the take-home message here is that we need to stick with gene drug pairs that have prescribing guidelines. When we stray from the guidelines, this is the type of scenarios that we should anticipate. Okay, so now just want to talk a little bit about analytical validity. Now, I realize that this is probably the least sexy topic in pharmacogenomics. Analytical validity doesn't even sound exciting, I know, but it's often overlooked, and it's important to really understand why I want to present this to you. It's because a lot of people think, well, my test is coming from an accredited lab, so analytical validity should be taken care of. But the fact is that it still can vary between accredited labs. And this is a particular case for the CYP2D6 locus. This locus is complex in that it contains two pseudogenes that sit in tandem with CYP2D6, and they both have high sequence similarity with CYP2D6. So you can see here in the figure, all three of these genes have 9 exons. And so it can cause a little bit of trouble and havoc for genotyping and creating assays. And this is because of complex structural rearrangements at this locus. So you can have a conversion in which you have a small piece of CYP2D7 inserted into CYP2D6. You can have hybrids where you have large sections of CYP2D7 inserted in the CYP2D6. You can have full gene deletion, which is often referred to as the star5 allele. And you can have duplications and multiplications of the gene. Here I'm just showing the duplication of the star2 version of the allele. Now, important thing to note about the duplications is that most labs do not report which allele is duplicated. Now, sometimes it doesn't matter, but a lot of times it does. And for an example, if we had an individual that's genotype was a star1, star4, and they said there was a duplication, but you didn't know which one was duplicated, the star1 or the star4, it depends, depending on which one is duplicated, changes the phenotype. So if the star1 was duplicated, you'd have a normal metabolizer. But if the star4 was duplicated, you'd have an intermediate metabolizer. And this can change the way that recommendations are made and advice is given for dosing and drug selection. Okay, so feasibility. So feasibility is really probably the base of where most of our biggest challenges in pharmacogenomic implementation sit. You know, at one time it was availability of testing that was the biggest problem. Now it's rarely a problem. As I mentioned earlier, we have an abundance of testing. So, and you can get it, order it through the internet these days. So getting testing is not a problem anymore. The acceptability of testing, that is also, I would say, becoming less and less of an issue. Providers, as well as the general public and patients, all purport having high perceptions of pharmacogenetic testing. I'm showing here a study that was done a few years back that asked primary care physicians and psychiatrists if they believed that pharmacogenetic testing would be standard practice. And you can see here that 82%, this was in 2015, said that they believe it would be standard practice. So there is this expectation, even among clinicians, that this is where we're headed. And so I don't think acceptability is currently a hindrance as far as feasibility. What still is a challenge for the field is testing turnaround. So currently, if you look at the laboratories and what they report, it's somewhere usually between 2 and 21 days from the time that they receive the sample to the time a result is in the hands of a clinician. And of course, this can be too long in some settings, particularly acute care settings where you need to start meds quite quickly. Now, if we went to a preemptive model, this doesn't become as much of a problem. But in our reactive setting or point of care kind of strategies, when you get closer to that 21-day mark, this obviously becomes a huge hurdle for implementation. And then finally, really the elephant in the room is usually the cost of testing. There's a wide range, it depends where you live, but even within jurisdictions, the costs are ranging widely from test to test. There's variable reimbursement rates, and I will tell you from our internal analyses that the cost of testing does not correlate with the quality of the testing. So in this case, you don't always get what you pay for. And so don't base the cost of the test on the quality that you're going to receive. Okay, so clinical efficacy is the next topic. And I will say that there's been 2 meta-analyses to date that have looked at the RCT evidence, and it supports pharmacogenetic testing efficacy, particularly in European adults with depression. Other populations, so other ethnic groups and other indications, anxiety, schizophrenia, they do require more study. And there's not even enough studies to do a meta-analysis at this point. So in our last year, we did this meta-analysis that's shown here, and you can see that adults receiving the pharmacogenetic guided antidepressant therapy were 71% more likely to remit. Now, since publishing this meta-analysis, there has been a new RCT that was published earlier this year. And I've just quickly, prior to this talk, just kind of put that in, and you can see that it has, because it was a negative trial, it has diminished the effect overall, but the overall significance is still there. So now we're looking at, pharmacogenetic guided antidepressant therapy. It was 46% more likely to remit, those that received it versus those that didn't. Okay, so something that's typically on the minds of most administrators is the cost effectiveness of pharmacogenetic testing. I can tell you that most evaluations suggest pharmacogenetic testing is cost effective or a cost saving strategy, particularly relative to standard care. And I'm going to highlight 3 studies that I think that show this. The first was a study done in 2018 that showed the delivery of pharmacogenetic testing reduced healthcare utilization. So there was a 58% reduction in hospitalizations, 40% reduction in emergency room visits, and 13% reduction in risk of visits to healthcare providers. Of course, this translates into cost savings as well. There's also evidence to suggest that pharmacogenetic testing reduces medication cost, particularly when the recommendations that are provided from the test are followed. So that's showing here in the blue bars. So doctors that follow the advice, which are called congruent, had reduced medication costs compared to those that did not follow the advice. And that was particularly shown strongly in the primary care physicians as well as the psychiatrist. Not so much in the OBGYN, but you'll notice that there was only 26 individuals in that arm, and they did show the same trend. And then finally, there was just as a comparison of 3 studies that showed the per patient savings. And you can see here that if we look at the per patient, we're somewhere between $6,000 and $7,000 per patient savings when pharmacogenomic testing is provided. So overall, I think it's fair to say that the cost effectiveness is, at least to date, is quite strong. And then I'm going to finish off with interpretation. And I think this is probably the, to me, the most important component because if you get everything else right that I said, you still have to interpret it properly. And it's a challenge sometimes to interpret pharmacogenomic results, particularly if you don't have some kind of clinical decision support. And so it's important to note that not all clinical decision support is created equal. And we cannot assume that they're all equivalent or interchangeable. And this we demonstrated in a study a couple years back, where we looked head-to-head comparison of results from 4 different commercial pharmacogenetic testing companies, and compared results, advice that was given. And you can see that less than 60% agreement in advice across those tests. So again, we can't assume that they're equivalent or interchangeable. And then finally, finishing off with, I think, the most important component when we're interpreting is that non-genetic factors do impact interpretation of pharmacogenetic test results. And this is a result of phenoconversion. So for those of you who are not familiar with phenoconversion, it's basically a phenomenon that converts a genotypically predicted normal or intermediate metabolizer to a poor or rapid metabolizer, or conversely, a genotypically predicted rapid or ultra rapid metabolizer to a normal, intermediate, or poor metabolizer. And that's the clinical phenotype. So why is this? Well, we know there's lots of inducers and inhibitors of these P450 enzymes. So if we use as an example CYP2D6, we have a CYP2D6 normal metabolizer. This person is prescribed paroxetine, which is a potent inhibitor of CYP2D6. Then we'd expect, although they're genetically predicted to be normal, in reality, because of that inhibition from paroxetine, they'd be considered a poor metabolizer. And this was nicely shown in a paper in 2013 by Presscorn that looked at 900 patients treated for depression and showed that if you just did the genotyping, you get about 4% of individuals that are poor metabolizers, which is what we'd expect. That's about right for a European population. But when you look at if you take into account drug-drug interactions and inhibitors and inducers, what you end up with is a 27% that are actual poor metabolizer phenocopies. So this is something that we do need to take into consideration when interpreting. It's not just something that happens occasionally. It happens more than we'd like to think. Okay, so I think I have a very couple minutes here, the last couple minutes, I'll just say some of my opinions on the future. And one of those is that I think for us to move forward, we really need to work towards capturing more of the complexity in drug response, or the variance, some would say, with the maximum amount of transparency. So right now, if we follow the pharmacogenetic-based prescribing guidelines, CPIC, Dutch guidelines, at most we're looking at 1 or 2 genes per drug. And so it's high transparency. We know exactly why they're getting to a particular recommendation, but it's low complexity. We know that it's going to be more than just these 2 genes that are affecting drug response. Then we have the commercial combinatorial pharmacogenetic tests, which take into account more genes, still handfuls of genes, but still more. So they've upped the complexity, but there's very low transparency because of the proprietary algorithms that are used to create the recommendations. So really what we're looking for is this ideal pharmacogenetic test that really maximizes that complexity with the highest possible transparency. And really what, very futuristic, what we're looking at is something like this. Today I've been focusing on just genomic variation, but it needs to be said that there's a lot of other omic variation, some of them depicted here in this figure, that really plays into drug response, along with the factors that could be part of that phenoconversion. So we have drug-drug interactions and environmental factors, as well as personal factors. And hopefully in the future, we get us closer to really more precise prescribing, where we can actually narrow it down to 1 or 2 drugs versus just a list of possibles and no-goes. Okay, I will stop there, and I'm happy to take any questions. And thank you for your attention.
Ted, that was really comprehensive and also very well organized. So it's a great way to think about pharmacogenetics. I guess I'll just make a couple remarks, because I can't help but look at your presentation through the eyes of Genomind. And first thing I want to say is we certainly agree that pharmacogenetic testing is not a magic card. I always say it's not the Academy Awards, it's not going to be an envelope that you turn over and this is the drug for you. So it's probabilistic, not deterministic. And there will never be a substitute for clinical acumen. There's just too many factors involved in the real world in treating a patient. Also, I think you mentioned that you mentioned 4 criteria for a laboratory, and I'd like to think that we meet all of those criteria. So, we're evidence-based and we're completely transparent about where the evidence comes from for our gene-drug associations. Our lab is accredited in New York State and also by CLIA and CAP. And as far as support tools, I think we have a really excellent support tool in our cadre of PhDs and PharmDs who provide consultations to requesting physicians. And finally, our turnaround time is less than 3 days. So I'd like to think that we tick all the boxes that you mentioned. And the last thing I want to say is that we include all of the gene-drug associations which you referred to, including HLA A and B. And more recently, I don't know if you know this, Chad, but our laboratorians invented a new HLA-A assay, and we found that the older technology, which some labs use and which we previously used, in which we used a tag snip to identify HLA-A positive people, had a 40% false positive rate when we did sequencing in a reference lab. So we've essentially eliminated those false positives with our new technology. So that's the comments I wanted to make. The final comment is that we certainly know that our patients, especially our adult patients, are on many other medications besides psychotropes. And that's where of course, the inhibitor and inducer thing comes in, which is kind of a multiplier for gene-drug interactions. We include GDIG, which is a software tool, a gene-drug interaction guide that our prescribers can use, which looks not just at psychotropic medications, but looks at phenotypes based on P450 genotypes and the drugs the patients are on. And so the prescriber can kind of test drive a drug in this software tool to see what the phenoconversion status will be of the patient. So that extends well beyond psychiatry. So those are the things I just wanted to put out on the table, and I'm happy to open it up to any questions from any in our audience. And one question had to do with your clozapine vignette. And the question is, why is clozapine used so much more in Canada compared to the United States? And does it have to do with PGx testing?
Oh, okay. Well, I didn't know that Canada was using clozapine more, but I'm happy to hear that. That's great. I think underutilized in general. So, so I can't really answer that of why it's being used more here than in the U.S. As far as PGx testing, I didn't present this here, but we've done a couple of studies related to clozapine pharmacogenomics. And to be honest with you, pharmacogenomics isn't really that helpful. If you know the patient's smoking status and any particular inducers or inhibitors of CYP1A2, you pretty much can dose appropriately for clozapine. The small amount of variance that the genotype provides you is I don't think at this time worth the cost that's associated with. So you're better off using standard kind of clinical workup for clozapine, I think, at this moment. It's a very active field, though, because if we can figure out who will respond to clozapine and who won't, it really opens up at being used earlier than as a just last resort kind of medication.
Yeah, I will say that our GDIG tool includes smoking and coffee consumption as lifestyle factors, so that can be evaluated. Of course, it's hard for even the most expert psychopharmacologists to keep all these gene-drug associations straight. So that's one reason to do pharmacogenetic testing in general. A question is, why has 2D6 poor metabolizer achieved a frequency of 4%? What might be the evolutionary advantage of being a poor metabolizer? And speaking also of evolutionary advantage, I'd also like to know about the 2C19 change in activity with age. That's kind of interesting and the opposite of what you might expect.
So it's a great question about, it's pharmacogenomic evolutionary kind of studies. I can say that in general, the pharmacogenetic variants are thought to have arisen or not arisen due to our ancestors and what plants they were eating and what regions of the world those plants were. So I can't specifically answer why CYP2D6, what the advantage of it is. It could be that the 4% is, because it is European, that they weren't exposed to the toxins that CYP2D6 would be breaking down in the environment. And so we've kept those from our ancestors, whereas in other populations, poor metabolizers are actually quite rare. And that could be because in their ancestors, if you ate the plants that were available and you were a poor metabolizer, you died. I can say the same thing for the other enzymes as well, but I'm not an evolutionary biologist, so I can't speak too much to it. But based on my understanding, that's probably the case of why it's still sticking around. I don't think it actually has an advantage. It's just that that people that have a poor metabolizer, their ancestors weren't exposed to the thing that would have, wiped them out.
Right. So can you posit a teleological reason why 2C19 might be more active in childhood than in adulthood?
Yeah, that's another good question. I think it's the activity is, again, it's the phenoconversion, right? So hormones, a lot of it has to do with probably hormonal things, but also other just biologically, neurobiological kind of processes. I think that's really what I think the state of the field would suggest, that it's, our biology is not static from birth onwards. And so these enzymes are kind of along for the ride sometimes because they are inducible and inhibited. So in other cases, at birth, you have really low expression of an enzyme and then it gets back up to adults. Right. So, you have the gas and the brake, and it depends during certain developmental periods. You might be pushing more on the gas or you might be pushing more on the brake.
Do you have any thoughts about how to account for multiple pharmacokinetic variants which might affect a single drug? For example, tricyclics and 2C19 and 2D6.
Yeah, so the TCAs, the current guidelines take into account both of those. So they have a little kind of a crosswalk where they have the CYP2D6 gene phenotype on the top and CYP2C19 on the side, and you kind of connect, and it'll give you the recommendation. And that's the idea for the future, is to do more of that. That's just a 2x2, but for some drugs, sertraline is a good example. We talk about C19, but it's metabolized by a number of enzymes. And so kind of throwing in more enzymes and more pharmacodynamics genes and variants would help in the future. But again, it has to be founded, based in the evidence. And right now we just don't have it. So the guidelines that we have now are what the evidence says we can use. And there's a lot of people working on more complex, like I said in that last slide, increasing that complexity so that we can increase the variance that we explain.
So, as you mentioned, we test, and other laboratories, commercial laboratories, test for a relatively small number of variants. So our lab tests 24 genes, 71 variants, plus 2D6 copy number variants. But, in the big picture of things, that's kind of a small number of genes. So what do you think the future is as far as, for pharmacogenetics, do you think that there's a future for polygenic risk in pharmacogenetics?
There's certainly a lot of people working on it. I'd say the variance explained is quite low at the moment, but and they're compiling huge numbers of patients in these studies. So I mean, I'm a bit conservative with the polygenic risk score. I think it's a good academic exercise. I think it's interesting. I don't know if it's to the point of clinical applicability, but I do think that maybe alongside other, like the CYP2D6, C19, because the polygenic risk score does not count for that because there's single variants, not haplotypes. So, I mean, I think it has a ways to come, but I think it has a promise. I just think it still has a ways to come.
Okay, so given the time, and we're very appreciative of your time, last question from Dr. Williamson. Is there any PGx testing that could make prescribing of MAOIs safer?
Not that I know of at the moment. And to be honest with you, I don't know anyone that's actually working on it because they're not used as much. I think it's more of everyone's focusing on SSRIs, and even TCAs don't get much attention anymore in the research area. It's maybe unfortunate because there's obviously groups of patients that do receive MAOIs, but to my knowledge, I don't know of any active research going on, and the research that has been done is inconclusive.
Okay, well, Chad, I really want to thank you for your time and kind of a great overview of psychopharmacology and PGx, and I hope that our audience found it useful. And this presentation will be available online. We'll send it out to the attendees at some point in the future. Thanks so much, Chad. Really appreciate it.
Thank you.